Esquivel. I've known Dr. Esquivel over 10 years now, I think, as we've met and crossed paths at various meetings and in different formats, and it's just been a great pleasure to work with him and to learn from him and to read his research that has come out. He's a prolific researcher in this field and has published and has advanced this field more than essentially anybody else in the peritoneal surface malignancy area. He is currently the National Director for HIPEC Research at Cancer Treatment Centers of America, and today he's going to speak to us about a new staging classification and a peritoneal surface disease severity score in Appendiceal Neoplasms. So, Dr. Esquivel, thank you.
Thank you very much, Laura. It is a pleasure to be here. I cannot tell you how excited I am. It's an incredible trip that combines all the different puzzles of this mysterious cancer with peritoneal metastasis. By the way, some of us are advocating for deleting the term peritoneal carcinomatosis and use more the term peritoneal metastasis. That way we are together with patients that have liver metastases, lung metastases, and we're seen as something that has, that is amenable to have a systematic and well-organized treatment strategy, as opposed to, you say peritoneal carcinomatosis and everybody says, oh, there's nothing to do, you know. So, with that in mind, I'm going to try to stick to the time because I know that nutrition is following. I don't have anything to disclose. You know, one of the things that Laura asked me to talk about also was about who I am and you know, how I've been able to do all these things in community hospitals. You know, I definitely do not have a laboratory or anything close to Avatar. You know, it's usually it's my laptop and myself and a couple of interested people. So over the years, you know, I have tried to describe what sustains my practice, and you know, my practice is based on these 4 pillars. We strive for clinical excellence. After all, you know, we're here to take care of patients, and that's our commitment. They put their trust on us, and therefore we have to do the best job that we can. But I'm also very focused on practical clinical research. So you can see here, it's practical, it's clinical, and then it's research. Again, like I said, I don't have a laboratory. We definitely do not have any kind of mice that we can be studying. And I have contributed with tissue to several organizations from time to time. So it's very exciting to see these meetings, you know, because you have patients, you have researchers, you have clinicians, you have groups that are interested in helping patients and helping the field. And it's really an honor to be part of this. And now that Dr. Giles is here, you know, I also want to thank him for putting this together with Jim Carroll and the PMP Research Foundation. So I also think it's very important to do education with cooperation. We all know that we can achieve a lot more working together, but it's not an easy task. You know, a lot of us surgeons are pretty hard-headed, and you know, the only thing that works is whatever I say or whatever I do, and it's very difficult sometimes. But through the years, you find the people that you can collaborate with, and as Laura says, I've known her for over a decade. You know, we were just finishing high school at that time. And it's always very important to give back to the community. And some of you may or may not know, but for the past 7 years, I've been going to Mexico. That's where I'm from. With my mentor, Dr. Paul Sugarbaker, we've been opening HIPEC centers in underserved areas in Mexico, and that has been extremely rewarding. So with that, then I will continue. I think the challenge that we have, and this is an evolving era, and it's always an evolving challenge, because we have to determine the right sequence of all currently available therapies. You know, we hear about bevacizumab, and for many years, everybody has been saying, you know, systemic therapy doesn't work on appendiceal tumors. And now we see, you know, from reputable institutions like MD Anderson, in which they have identified a subset of patients. So I think it's not those categorical statements, everybody needs cytoreduction and HIPEC, or everybody needs chemo, or everybody does not need chemo. Those are very difficult statements to make. And I think that as we learn more about the process, we need to try to incorporate at the right time everything that we have. Having said that, I think that one of the main problems that we have is that, this pre-treatment. So appendix cancer, is just a name, but it has a middle name, it has a nickname. There's so many ways to describe appendix cancer. And I apologize for saying this, but the PMP, the pseudomyxoma peritoneal, later on I'll show you that I think that PMP stands for perhaps multiple pathologies. And I really, even though this latest classification that Laura showed, which we're both part of, you saw it's just not it's not very practical. And as we are involved in this field and we see it and we still say, oh boy, now imagine a pathologist that sees 1 or 2 appendix cancer cases a year is going to be not too interested. So I think there's still a lot of work that needs to be done. But the basis for treating patients, I think, is to try to get the patients in the same group. So we're comparing, a very specific histological with biochemical, with biological designation of one patient to the next one, and not just say, well, this patient has PMP and this other one has PMP, and they're completely different. So when it comes to selection criteria for appendix cancer, I think everybody would agree the treatment is going to be cytoreduction and HIPEC. I think, the earliest referral that I have gotten is from a patient from the recovery room who went to surgery for an appendectomy for appendicitis, and then they found that it was a ruptured mucinous tumor, and they said, well, we don't know what to do, and you need to call somebody. And well, in the recovery room, the patient started looking up, and they gave me a call. And so I think that anybody that has an appendix tumor, one way or another, is going to end up being evaluated by somebody who's familiar with appendix tumors and is going to receive the right treatment. I think that the outcome after the cytoreduction and the HIPEC is going to be influenced by the PCI, so how much tumor is present in the peritoneal cavity, whether the tumor is high grade or low grade or has positive lymph nodes, but a lot also by the experience of the cytoreductive chemo. And sorry, I do have some gross pictures. So this is a classic CAT scan of somebody with an advanced pseudomyxoma. Luckily, I don't think that we're seeing too many patients like that. They're being referred a lot earlier. And, here is the culprit. This tiny little appendix tumor has, gotten someone that requires an operation so big like this, which removes small bowel. This is the greater momentum with the spleen and part of the pancreas all the way down into the rectum, just because of this tiny little tumor, which here, by the way, you see is not even perforated. So just the fact that you have an appendiceal mucinous neoplasm that is not perforated doesn't mean that it didn't perforate before and then it's sealed. So it's another thing to keep in mind. And I think that everybody knows that the treatment is cytoreduction and HIPEC. I operated on a patient from Berlin, and these are her 3 grandchildren that came and wearing those shirts. And here it says, get that pseudomyxoma out of my oma. And I've been told that oma means grandmother in German. So I said, everybody knows that the treatment of pseudomyxoma is to get it out. However, this is 2015, and as I mentioned, not all the patients present the same way. Not only do they have different tumors, but the mode of presentation is different. Here's an example of somebody who just went for a laparoscopy for acute appendicitis, and look at this, just a tiny little bit of mucin coming out of the appendix. By the way, this is the inflamed appendix, and these are the small bowel, but that's it. So a patient in that situation has to be very different than the picture that I showed a moment ago. Here's another example. We know that we all have fluid in the abdomen, and the fluid moves in a clockwise fashion. And this diaphragm, this muscle that separates the chest from the abdomen, 18 times a minute moves up and down, and it drags some of that fluid and some of that little mucin that came out of the appendix. So this is the undersurface of the right hemidiaphragm, and I know it doesn't project very well because of the light, but it's okay. This is the liver, and this patient has just a couple of mucinous implants that you were not going to be able to see on a CAT scan. And so how to counsel patients with this volume of disease is a very ongoing challenge. Here's the one that I mentioned. So a non-ruptured, what appears to be non-ruptured mucocele, and when you do a cross-section, look at this, just filled with this mucin, and you can imagine this is just like a time bomb, you know, this will rupture and then all that mucin will distribute. And, you know, I presented this slide one time in a conference, and like, oh, here's the patient, you know, what should we do? Because now, forget about what you can see, but this is just under the microscope. And so here is, you know, the tumor is ruptured, but only at the microscopic level, and here is a little bit of mucin outside of the appendix. And I'm sure Dr. Mizrahi talked a lot about this particular situation last year, and said, well, this is a patient with a low risk. You know, but how low is low, and what is a risk, and, you know, is there anything I can do to prevent the risk, or you know, what do we do? So there are a lot of questions that need to be answered. So with that, I'm going to talk about the way I want to call this is mucinous appendiceal neoplasm. Because as Dr. Lammer showed in some of those SEER studies, you know, appendix tumors are very, very common. You know, and a tumor doesn't mean some kind of abnormal growth. It doesn't mean it's cancer. And we have, you know, anywhere from adenomas, carcinoids, and then mucinous appendiceal neoplasm that can be also benign, even though with a malignant behavior, or they can be malignant with a quite virulent behavior. So through the years, there have been some attempts at classifying this, you know, since 1973. Then Dr. Carr, which is the same first author for this 2015 publication, so 20 years later, he was trying to do this, and apologizes. Yeah, some of this is in Spanish. One of the classics is the DPAM, the PMCA, or the intermediate, you know. And so one of the things that we have seen is that not everybody fits into the category of DPAM or PNCA or intermediate, you know. For example, here, we don't talk about signet ring cells. The PMCA will include anything from a well-differentiated invasive tumor to a signet ring cell tumor, which are also not the same. And then Dr. Pai started focusing. One of the things that I have always had is I said, well, tell me the staging classification of any solid tumor in which the primary tumor is not part of that classification. It doesn't make any sense. You have colon cancer. Well, you go PNN, you know, tumor, and then the T is going to be determine how thick of an invasion is the tumor. In breast cancer, the T is going to be how big the primary tumor is. But then when it comes to appendix cancer, we use DPAM, PMCA, and it doesn't tell you anything. I mean, they just completely disregard the primary culprit, you know, which is the appendix. And to me, I just don't know, you know, that makes sense. So that's what I'm trying to follow on Dr. Pai's evaluation. He said, well, you know what? Maybe we should group the primary tumor, you know. So he got 4 different groups, and then, as I mentioned, with low risk of recurrence or high risk of recurrence. But the problem that I have is that on these publications, and I'm sure also what Dr. Mizrahi presented last year, okay, so now he's focusing only on the primary tumor, but it doesn't tell you anything about the DPAM or the PNCA. So I said, well, someone has to come and put all these together. And so mucinous appendiceal neoplasm is the term that I would prefer to use. You know, pseudomyxoma peritoneae is a syndrome. It's not a histological diagnosis. It's a syndrome that is better known as a jelly belly. You know, people will present with an larger abdomen. The most common form of presentation in female patients is an ovarian mass, and I don't have to tell this audience, you know, how many times that gets treated, not only diagnosed, but treated as ovarian cancer. But all they need is a good cytoreduction instead of getting chemotherapy. But so I think that we do need to evaluate the primary tumor. We also need to evaluate the type of peritoneal dissemination, and most importantly, is also how much tumor there is. So we really need a classification that would incorporate all that. I think that I read a paper on the American surgeon about a shark bite severity score. And the plastic surgeons at the University of Gainesville, Florida, developed a shark bite severity score for the paramedics to be able to determine, how serious was the shark bite at the beach when they had to pick up the patient and take them to the hospital. And people think that I'm making it up, but it is published on a peer-reviewed journal. And then I said, how can there be a shark bite severity score? We don't have one for peritoneal carcinomatosis. At that time, I was still calling it carcinomatosis. And so, I said, well, I think that severity is the single most important predictor of outcome in any problematic situation. It's raining a little bit right now, When Dr. Lambert picked me up this morning, he said, I said, no, it's just a little, just a mist, so don't worry. It's okay, we can just walk without the umbrella. If it's raining a lot more, well, now you need an umbrella. If it's tsunami or whatever, we have to go and look for shelter. So depending, it can be just rain. So picture that the appendix tumors are the same, they come in different levels of aggressiveness. And getting back to that presentation this morning, the latest version of Dr. Carr, it may be reproducible, yes, because everybody can look at it, but it's not practical. It's going to be very difficult. And I think also very important, any classification should have some prognostic significance. So then you can tell the patient, you are in this group, we treat you this way, this is what is the expected outcome, at least, have a baseline of where to start. And what I think is the most important thing, it needs to help us to establish the sequence of available therapies, because the available therapies keep changing. And so you can't use the cookie cutter approach and say, appendix cancer, cytoreduction and HIPEC, or appendix cancer, chemotherapy, if you can do cytoreduction and HIPEC. So there's got to be a way to evaluate, the different combinations. And if you say, well, you were in this severity score, this is how we treat you initially. If you get this response, then we'll move to this one, and then you can, have complicated algorithms of therapy, but that at the end of the day, translate into better benefit. So we put this through the American Society of Peritoneal Surface Malignancies. We put together this peritoneal surface disease severity score in 1,048 patients with colorectal cancer. And then here was peritoneal dissemination. So we didn't like the carcinomatosis. And I'm just going to show you the outcome of these patients treated with cytoreduction and HIPEC, but staged by this severity score. And the severity score is very simple. It's something that you can do without even having the patient in your office. It's something by information that is available through the histology, through the CAT scan, and through the clinical symptoms. And you can see here, 78 patients with a score of 1, the median survival was 81 months. That's a very impressive number. But the difference for those that had a score of 4 was 27 months. So you can see that even though all these patients have colon cancer with peritoneal metastasis, and they were all treated with the same strategy, cytoreduction and HIPEC, the outcomes are very different, statistically significantly different, even though it's the same therapy. So with that, we said, okay, well now it's time to come with a peritoneal surface disease severity score for appendix. And while the colon wasn't too complicated, and then we said, well, we just need a little, CAT scan histology and the symptoms, we found out that for the appendix, it was a lot more complex. It wasn't that simple of just getting a few little numbers. So I was lucky that Dr. Susana Sanchez Garcia was visiting me from Spain, and so we analyzed, we looked at 384 patients with mucinous appendiceal neoplasms during my time at St. Agnes Hospital in Baltimore. And it's a retrospective study, but just to see, can we identify patients in different groups that even though they were treated the same way, have a different outcome. And so, again, this gets a little complicated too, but I'll walk you slowly through this. So, we want to use G for the primary appendiceal neoplasm. Again, because I don't know of any solid tumor that, like that the primary tumor is not part of the staging. And expanding a little bit more on what Dr. Pai had reported, we said, okay, well, group 1 is going to be patients with the mucinous adenomas, non-rupture. These other ones were exactly the same. Group 2 you do have a ruptured tumor, but there's only mucin, so therefore you're low risk. You have mucin, but also cells that make that mucin outside of the appendix, so that would be a high risk for recurrence. And then this space here is on purpose. I said you cannot compare a low-grade mucinous carcinoma with a high-grade or a signet ring cell. And so we want to give, patients a different group category of their original tumor. As later on, we find out there was no difference actually between the high grade and the signet ring. So this group 5 and 6 became together as a group 5. Why? Because we also were able to do all these fancy statistical calculations now based on what we have learned from the severity score from colon cancer. So that's one thing. Then we also have to evaluate the type of peritoneal dissemination. So P0, you don't have any peritoneal dissemination. And then I said P1, okay, fine, you only have mucin, but not tumor. And then Q, you do have some epithelial cells, but there are no signs of invasion. So it's just what we call a true DPAP. No evidence of any cancer. And then P3, you have an invasive cancer, and it's well or moderately differentiated. And then P4, you have invasion, and now you're fully differentiated of signet ring cell. So you can imagine that when they start combining all these possible, you're a G1 with a P2, and we still have to get to the burden of disease, it starts to get a very complex severity score. So the extent of disease, we know that PCI is probably the single most important predictor of outcome in colon cancer. PCI and CC score, which means the completeness of cytoreduction score. So how much tumor you have, and then how much tumor you have after the operation. So those are very important, but those require an operation. And if you're not a candidate for surgery, well, you want to find that out before you have the operation. So here, we use a CAT scan, and we say, E1 would be for PCI of 10 or less, 10 to 20 would be in moderate volume, and high volume would be greater than 20. And with that, of course, talk about simple and reproducible. It comes this complicated score in which I wanted to keep it to four stages, but then I realized that there were going to be patients that had no peritoneal dissemination and no evidence of disease on any kind of imaging study. So we had to add this stage 0, and then 1, 2, 3, and 4. But then to be able to fit all these possible combinations, then we came up with 1A, 1B, etc. So it does get a little bit complicated, but we'll narrow it down to the different stages. So of the 229 patients that we evaluated, because remember, we needed, even though we had 384, we needed to get the primary tumor. And a lot of patients, they just get referred and they come labeled already, well, I'm DPAM or I'm PMCA, and you never go back and look at what was the primary tumor. And then later on, I'll show you why the primary tumor is extremely important, which makes a lot of sense, and I cannot believe that it took me just until like 2 or 3 years, at the time, 4 years, to realize that. Now as I'm saying it, I say, wow, it makes a lot of sense. Anyway, so there were 19 patients with a score of 0, and these 19 patients are going to be excluded from the cytoreduction and HIPEC because we didn't do cytoreduction and HIPEC on these patients that didn't have any evidence of disease. And then a large, kind of not too different, 60, 59, 43, and 41 of the different stages. And when we look at this median overall survival in those patients that got HIPEC, so of course not everybody gets HIPEC because we try to get patients to the operating room, but sometimes we cannot do the operation and we don't do HIPEC. And there were a couple of them there that didn't get HIPEC. One because the machine broke and we just couldn't get it fixed during the HIPEC part. And then another patient who developed some kind of almost fatal arrhythmia just before starting the HIPEC. And then and there's another patient for another reason. But nevertheless, when you compare the patients, and I know it's hard to see from the back, so we got 229, but we excluded those 19 patients. So 173 patients that had HIPEC, this is all comers, okay? This is all, low grade, high grade, signet grade, etc. You can see that the outcome is pretty good. Median survival of 18 months, but it goes from 58 to non-breach. And then even in those patients that we couldn't do the HIPEC, it was 37 months. And when we break them down by this severity score, then you can see for those that had a score 1, well, the median survival has not been reached, not even for stage 1 or for stage 2, whether you got HIPEC or you didn't. So kind of like a little intriguing. And then stage 3 and stage 4, those are the patients that have true cancers, and you can see that there's a difference now between those that got HIPEC and those that did not get HIPEC. And very similar to colon cancer, the outcome of patients with this severity score of 4, which meant patients that had signet ring with a large burden of disease and peritoneal dissemination, not just mucin, but from invasive cancer, is very similar to colon cancer. And this is a complicated slide, but just to show that from the statistical standpoint, to do this fancy calculation of univariate analysis and multivariate analysis, and the bottom line is that at the end of all the statistical evaluation, the only thing that made a difference was, as usually happens, female patients tend to do better than male patients, and the stage of your severity score. All the other ones, the group by itself, the peritoneal dissemination by itself, or the burden of disease by itself, were not statistically significant. And when we analyze the survival curves, you can see, I show you the ones for colon cancer, they separated quite nicely, but here they separate even more. And you have here this group of patients now out to 100 months, and everybody is doing extremely well. And so we say, well, and all these patients were treated the same way, but what I'm trying to get is that you cannot expect the same outcome with the same treatment. What determines your outcome is a better understanding of the biological behavior of your tumor. And so, yes, we see somebody with a little bit of disease and we say, oh, you need cytoreduction and HIPEC, and then here's the outcome for those patients. But as I'm going to show you later on, I'm going to show a group of patients who are in this category who did not get cytoreduction and HIPEC. Some of them got it laparoscopically, some of them, all they got was an appendectomy. And I guess this is the HIPAA violations are not looked at today here with patients. No, just kidding. But there's somebody here in the room that I was very happy to hear that the 5 years out, and he or she may be wanting to comment about this later. And so you could almost put a line here comparing these two curves to these two, and you can say, well, maybe this is what we will label DFAM and this is what we will label PMCA. But even though between those two, there's quite a bit of a difference. I think we still have some ongoing issues, as I mentioned before. I think it's time to retire the term PMP because a lot of patients will come and say, well, I have PMP, and then you go on the internet and you look and you even talk to other patients, and one has the DFAM version of PMP and the other one has the signet ring, and they expect, that the outcome of the treatment is going to be the same because pretty much, like I said, the cytoreduction and HIPEC, but the outcome is going to be completely different. And there are patients like you here, who would come and be educated and learn about this, but there are a lot of other patients out there that all they heard is, well, I was told I had pseudomyxoma. And even healthcare providers, they will call a signet ring with extensive peritoneal disease, and like, oh yeah, this is pseudomyxoma. And throughout the world, the French have tried to call PMP1, PMP2, PMP3, and I think it makes it a little bit more complicated. I also think that almost all patients with appendix cancer, like I said, that need cytoreduction and HIPEC are getting it. We talk about how we're going to determine, well, prospective randomized control trials are very, very difficult in the surgical arena. When you're a medical oncologist and you compare drug A to drug B, well, it's the window between the difference of those therapies is very small. In surgery, if you want to compare surgery versus no surgery, well, it's very difficult. And then, without a doubt, we all associate the good outcome to the HIPEC component, and even though that has never been proven, and we all sell this as a package of cytoreduction and HIPEC, and the good thing of that, as I say frequently, is that it has allowed to keep the care of all these patients in the hands of a few people who really know how to do the cytoreduction and do the HIPEC. But with the ongoing randomized trial from France that is going to demonstrate that the most important component of the treatment is the surgery and giving systemic therapy for colon cancer, I am very concerned that what we're going to see is a lot of surgeons out there doing the cytoreduction, themselves, because there won't be need to do the HIPEC. So it's a little bit concerning, but something that we will have to keep in mind. And more, I think that HIPEC, we have to identify the patients that really benefit from it. We keep trying. We know that not everybody benefits from the HIPEC. In Europe, the latest thing right now is to do prophylactic HIPEC, as Laura showed on that slide from the trial from Dr. Elias. And I think that that's going to be even more difficult in this country. I tried to do a trial like that, and my IRB said no, absolutely, not even, they wouldn't even review it. Said this is an administrative decision, no. You cannot submit this trial to the IRB, trying to do prophylactic HIPEC. And and certainly the insurance companies are not going to approve that. I think that we also have to keep in mind that there is a subset of patients who have a true pseudomyxoma in which the outcome is extremely well, and you're going to have to follow these patients for a long time. And we know that there are risks associated with this massive number of CAT scans that we put our patients through. And so we are working also on doing MRI, which we would do in a pregnant patient, because there is no ionizing radiation. And so I also have tried to do laparoscopic cytoreduction because, like I said, well, if the patient just needs a small operation, why not try to do it, minimally invasive? There is no established cancer inside the abdomen that in 2015 is not being treated laparoscopically. Even pancreatic cancer. University of Pittsburgh just reported 200 robotic pancreatic duodenectomies, for pancreatic cancer, which is a much more aggressive tumor than a true pseudomyxoma. And as Laura mentioned, more and more we're going to start understanding the role that systemic therapy, meaning chemotherapy, is going to play in the treatment of appendix cancer. So this is an evolving field, and this second part of my talk, I'm just going to present to you a little bit of what we're doing. So, all politics are local. I'm at the Cancer Treatment Centers of America, where we focus a lot on doing genomic profile analysis. So trying to determine, what exactly does your tumor have that we can identify if there's any mutation that we can target. And so I had the opportunity to evaluate 15 patients with mucinous appendiceal neoplasms that were treated with cytoreduction and HIPEC, and that we were able to do that genomic profile analysis. As a little bit of a background, we do know that there's a small subset of patients, about 5% of them, that have this called true pseudomyxoma peritoneal that do not behave like that. They behave as a much more aggressive tumor. And usually they experience a rapid recurrence after a complete cytoreduction and HIPEC, and they fail to respond even to systemic therapies for colorectal cancer. The outcome is usually very poor, and Dr. Sugar-Baker calls them the pseudomyxomas. So what we did is that we ran this genomic profile analysis of these 15 patients that I mentioned that were evaluated at my institution in Philadelphia. They all had cytoreduction. Some of them at CTCA, some of them at another institution that I was before. And I grouped them based on the most common classifications, the DPAM versus PMCA, or the low grade versus high grade. And we also identified any possible therapeutic options based on these particular mutations. And then the standard follow-up evaluation was done. So there were 9 female patients and 6 male patients. The mean age was 49, as Laura mentioned in one of the studies there was 51. So I think 49 is the average age for appendix tumors. The mean follow-up from diagnosis was a little bit of 5 years, but some of them long follow-up. And 40 months, from 1 to 152 months from the time they got HIPEC. And only 1 patient of those 15 had died at 80 months after having the cytoreduction. What we find is that all 15 patients had at least 1 genomic alteration, and a total of 36 mutations were identified. This GNAS KRAS was the most common in 80% in 12 patients. And then we found these SMAD4 and SMAD2. KRAS is very, about 40% of patients with colon cancer have this mutation, so we know a lot about that. And these other ones, this SMAD mutation, we know about it from pancreatic cancer, and it's usually associated just with a bad clinical picture. And one other mutation in 7 patients. When we classify the patients based on the most common classifications, 7 patients were DPAM, 40, so half of them, and then the other ones, as you can see here. 13 patients, 86% will fall into the low-grade mucinous carcinoma, and 13 patients on their high grade. When we look for this GNAS KRAS mutation, 100%, so 7 out of 7 patients that were classified as DPAM had this particular mutation, and none of the PSDSS patients. So I know the numbers are very small, but I start thinking and say, okay, well, if I have a patient and I see that has a GNAS KRAS mutation, and that's the only mutation they have, well, I feel pretty comfortable that under the microscope, they look like DPAM, they are a true DPAM. And then on the other hand, if they look like DPAM, but they don't have any of those, I said, maybe this is more looking towards PMCA. Remember, when we do a cytoreduction, you take a tremendous amount of tissue, and it is impossible to evaluate every single thing that you take out. But what is always possible, would be to evaluate the primary tumor. And again, I'm going back to, so why does my primary tumor look like? Because that's what's going to determine where do you fall later on. And then when we looked at patients that had one of the two, either a GNAS or a KRAS mutation, again, all the DPAMs did, even the intermediates, but not the PMCAs. And again, when you divide it, so if you don't have GNAS or KRAS, then chances would be that you were in the high group category. Now, let's focus a little bit more on those 7 patients that under the microscope had what we call true DPAM. So 7 out of 7. GNAS and KRAS was the only mutation on just less than half of those patients, 3 out of those 7 patients. And then you see here, no evidence of disease at 5 years and 7 years, and even one patient alive with disease but 14 years from the cytoreduction and HIPEC. But when we look at these other 4 patients, this patient had this check 2, I don't know, I confess I don't even know what it is. The patient had a high PCI, but it was with no evidence of disease 12 years after cytoreduction and HIPEC. But when we look at those patients that had the SMAD mutation, even with a low, moderate, or high PCI, they had a recurrence at 2, 6, and 8 months. And this is after a complete cytoreduction in patients that were supposed to have just DPAM, which when you see a patient like that, especially this patient, with a low PCI, and you do a complete cytoreduction, you say, oh, listen, everything is great, you're going to do fine. But then that patient came back to me with a recurrence, at 8 months, and that's when I said, well, let's see, what else can we do? And we start getting information about that genomic profile, and wow, then we find that, this patient was in that same group of the ones that had a recurrence. So we're starting to learn a little bit more. Now, what about the PMCA? They don't have GNAS or KRAS mutation. Here's just those 2 patients. Look at this, PCI of 30. So a tremendous burden of disease from a high aggressive tumor who had an incomplete cytoreduction, and at 26 months, and this is even more now than that, the patient is doing great. He's getting Folfox and Avastin, and the patient, we've been following him for quite a while. Patient number 2, that had also a SMAD mutation with a PMCA, who had a PCI of 14 and underwent a complete cytoreduction at 4 months, developed a recurrence that rapidly progressed into biliary and urethral obstruction with a very poor clinical picture. Now, I know these are very small number of patients, it's only 15, and of course, of the PMCA, it's only 1 patient. But I'm starting to see okay, there seems to be something in common here. And something very promising is that when we look at all these mutations and we say, well, so you send these to whatever group is going to do your genomic profile analysis. Then they will report not just the mutation, they will tell you also, are there any drugs available to treat this particular mutation? And then they'll give you the list. And of course, in a lot of them, as you see here, 86%, 13, 33%, are going to be drugs that are used in another treatment, in another tumor. Like this one, called trametinib, that was, 86% of the patients were eligible to target that mutation. This drug is used for melanoma. So they're going to see, are there any drugs that can be used for targeting this tumor, meaning appendix cancer for the disease? No. And so there's a problem. We try to do a study using trametinib, but it's very difficult. These drugs cost about $12,000 a month, and try to get it approved from insurance, it's very, very complicated. But more and more, so here are names that you rarely, this one, yes, we know, but rarely would you see these names, when we talk about gastrointestinal malignancies, and definitely not when we're talking about mucinous appendiceal neoplasm. Dr. Lambert had described this, but without the clinical correlation, and that's what I would be so interested to see if Dr. Jazz can pull it off to find this interaction between, look at this 18 patients, 18%, 28%, 28 patients of these, I think there were 50 some patients had the SMAD4 mutation. So very, very interesting to see the implication of having a SMAD4 mutation. So the conclusion of this study, and I have a few more slides, so it's not the last one. I think this data confirms one more that there's a difference between mucinous appendiceal neoplasms and colorectal cancer. This genomic profile analysis allows us for establishing diagnosis. How many times do we see a patient whose tumor is at the base of the cecum or the top of the appendix, and they'll go see someone and say, oh no, you have colon cancer, and then you'll see one of us and say, oh no, this is the top of the appendix, so it's an appendix cancer, and they get treated quite differently. Well, when you do a genomic profile analysis, they're very different, the ones from appendiceal tumors and from colon cancer. I think it also helps to unveil this pseudomyxoma, and at the present time, all I can say is that the presence of the SMAD mutation appears to be associated with the worst outcome, but I don't, if someone comes and tells me, I have a SMAD4 mutation, what should I do? It's going to be difficult. I'm trying to look for clinical trials, and it's a little bit beyond my understanding, but this particular gene, the SMAD4, is a passive aggressive, so sometimes it enhances tumor growth, sometimes it regresses it, so there are not currently any drugs that are targeting SMAD4. So a little difficult, something for the lab would be a great study. And the genomic profile analysis has identified new therapeutic options, but I think that these therapeutic options need to be evaluated in clinical trials. And now, for the last part of this presentation, another thing, I think we always, as clinicians, you have to always look back and see what you're doing and how you can keep learning to make sure, like I said, our obligation is to provide treatment for our patients, but it should be also the right treatment. And sometimes, we all want to be very aggressive, and I think, again, that there are a lot of patients that are going to do extremely well with cytoreduction and HIPEC, but I could almost say despite the cytoreduction and HIPEC, because perhaps they don't need it, and if you do enough surgeries, you're going to have complications, and so therefore we should try to be completely sure that that's what patients need. So I went back and looked at 59 patients, these are all my own patients, and compared those that had just an appendectomy and that we were following, or they had cytoreduction and HIPEC. And so the same thing from the prospective database, we analyzed these patients and gave them the peritoneal surface disease severity score, and we analyzed those that had a negative peritoneal metastasis protocol MRI or a very low PCI, 5 or less at the time of exploration. Out of 405 patients, so this is more recent than my previous presentation, so we identified the score in 245. 92 of those patients had an early stage, and 59 of them had a non-invasive mucinous appendiceal neoplasm. So they will follow more into the category of DPAN. These were not invasive cancers. There were 29 in Group A that had an appendectomy only, and 30 on Group B that had a cytoreduction and HIPEC. The follow-up was on average a little bit more than 3 years, and it was a little bit bigger, almost 4 years for those that had cytoreduction and HIPEC, because that's how we were treating everybody. But the surprising thing is that all 59 patients are alive, and one patient in the appendectomy group developed a recurrence, and one in the cytoreduction and HIPEC, which I showed you before, developed a recurrence. By the way, some of these patients that had cytoreduction and HIPEC were treated laparoscopically. So there was actually no difference whether we did. I tried to write it that way, but then the numbers get smaller. There was no difference really whether you had an appendectomy only, whether you had an open cytoreduction and HIPEC, or whether you had a laparoscopic cytoreduction and HIPEC. And I hope that, in the near future we can develop a study with a collaboration from multiple centers and try to learn more about how these patients should be treated. So the final conclusion is that mucinous appendiceal neoplasms represent a spectrum of tumors with a very wide range of not just histological features, but also biological aggressiveness and how they present clinically. I think that this precise pre-treatment stratification is extremely important to evaluate the impact of all available therapies that we have, because we have to start, on the same start line, and we have to group patients. For anybody that runs, they put you together based on your previous performances. So it's the same thing, you can be a marathon runner, but the guy that's the elite runner at the front, you cannot ask the one at the back to do the same. So again, groups, putting patients into groups that are in other groups that share similar primary tumor, similar genomic profile analysis, similar burden of disease. I think that's what we should aim for. And so, even though a very small number of patients, I think that this data suggests that not all the patients with the mucinous appendiceal neoplasm may need cytoreduction and HIPEC, and that the peritoneal severity score and the genomic profile analysis may assist on tailoring personalized treatment. To give you just an example, I saw a young woman who had an appendectomy for appendicitis, had a ruptured mucinous appendiceal neoplasm, and had a positive margin at the base of the appendix. And she went around and saw different peritoneal surface malignant centers, and somebody recommended a right colectomy because you have a positive margin. Somebody else recommended a cytoreduction and HIPEC because this is the mucinous appendiceal neoplasm. Of course, she's 37 years old, and what she wanted is to have a child. And then she came and saw me, and I said, well, I displayed all the information that I had. I said, what I would do right now is send your primary tumor for a genomic profile analysis. It was a GNAS, KRAS, nothing else. I said, listen, this puts you in a very good category. There is literature, probably Dr. Misraki presented this last year, that positive margin when you go back is always negative. And with all that information, and we got a peritoneal metastasis protocol MRI, there was no evidence of disease anywhere. She had normal tumor markers, and just a couple of months ago, she sent me a note just telling me that she has a healthy baby girl, and she's going to get a repeat MRI. So I think that there's definitely practical information that we can gather from information that is already there. So think about, what does my primary tumor look like? Because the answer, I think, is going to be there. Thank you very much for your attention.
Thank you very much, Dr. Esquivel. That was a fantastic lecture. And you can see how he is really a thought leader in the management of appendiceal cancers and carcinoma, peritoneal metastases. I like it. I think that's good. So next we're going to hear from Kelly Balcourt, who is one of our nutritionists here at UMass. Kelly is extremely essential and helpful in managing our patients after surgery with their nutritional needs, and certainly if anybody needs to be on intravenous nutrition, she plays an enormous role in that, and it's been a pleasure to work with her and help take care of people with her. And she's going to talk to us today about nutrition and well-being during after cancer treatment, which is something that comes up pretty frequently.
Hi everyone. My name is Philadephia, and I've been a registered dietitian for 13 years now. The last 8 of them being at UMass, and the last 4 or so, 3 or 4 or so being at the home infusion company for UMass. I wanted to start with some quotes to live by, because I think it shows a good picture of why this talk is important. And my favorite, I think, out of that slide is don't eat anything that your great-great-grandmother would recognize as food. And I think that's a good thing to watch for. So today, I'm going to go over the importance of good nutrition and why that matters in terms of cancer prevention and cancer recovery. Also, I'm going to talk about the American Cancer Society guidelines for cancer prevention and cancer survivors, and go over some more details about the diet and physical activity. And then I'm going to talk a little bit about recovering from surgery and some dietary interventions for potential side effects of your treatment. So let's first talk about why diet is important. We all know that research shows that poor diet and lack of physical activity are 2 key factors that increase a person's cancer risk. And the nutrition guidelines for cancer prevention and cancer, while we're going through cancer treatment, are similar to those for preventing other diseases like heart disease and diabetes. So by following their guidelines, you're kind of preventing other diseases as well. And then there's your benefits of good nutrition during cancer care, which would be, to support your immune system, to decrease your infection rate, and to preserve your lean body mass. So what about weight? Getting to and staying at a healthy weight is probably the most important thing we can all do, and this